My name is Dr. Mike Maskill, and I just wanted to tell you a little bit about myself first. I grew up in Grand Rapids, Michigan, and subsequently went to Grand Valley State University for my undergrad. I then went to the Chicago Medical School for my medical training, then on to Pittsburgh for residency, and I finished up in Portland, Maine. I kind of did a little roundhouse there on the East Coast and did a foot and ankle orthopedic fellowship out there. So I am a podiatrist, but I did an orthopedic foot and ankle fellowship, so I'm kind of a hybrid. So I kind of, pick and choose from both ortho and the podiatry end of it to kind of formulate, what I think is, some pretty good treatment plans taking from both specialties, which is great. So that being said, I moved here from Portland, Maine 9 years ago. I started practice. So I've been in practice for 9 years. I pretty much started in the Watervliet area right out of the gate. So I've been in this community for about that time. I currently practice with Dr. Jeff Postma, who's general orthopedics here in town. And I actually recently brought in my brother, James Maskill. I don't know if any of you have met or know him, but he's in St. Joe now, and he's been in practice for 3 years. So we kind of tackle this area together. He actually has the same training I do, so both ortho and podiatry, so it works out very well for us. So that being said, I chose the topic of bunions and hammertoes primarily because everyone has a general idea of what they are, and everyone's heard some horrible stories about bunions and hammertoes as well. And I kind of wanted to talk about it to dispel some of the myths and answer any questions ultimately that people have about that, because they're extremely common. We see them several times a day. People end up having, significant issues with them. And it's something we treat all the time, and a lot of people, it's a quality of life thing. So that's why I felt this is a good topic to address. So the reason I incorporated both, I was originally just going to do bunions, but I added hammertoes because the majority of the time, bunions and hammertoes go hand in hand. A lot of people have both of them. And the main reason is because bunions, as the toe deviates towards the second toe, actually end up causing hammertoe deformities. So the majority of the time, we don't really see too many hammertoes in isolation. They're typically associated with bunion deformities. So I thought it would be good to talk about both at the same time. So we're going to initially start talking about bunions. We're going to hit what is a bunion. A lot of people know really that it's a bump on the inside of the foot, but they don't understand why it happens and what it truly is. We're going to talk about symptoms that develop as a result of a bunion deformity, how they develop, and various treatment options, both surgical and conservative. So, what exactly is a bunion? It is definitely more than just a bump. A lot of people think that they develop some bony prominence that grows and grows and grows, and it's a bony overgrowth, and that's what a bunion is. It's actually not that. What it is, more than anything, is it's a positional problem and an instability problem. So if we go back to this picture here, you can see this is the first metatarsal bone, which is the bone behind the big toe. Okay, so you have the big toe here. So really what the bump is it's a deviation of this bone away from the second metatarsal, which is the bone behind the second toe. And when that happens, the big toe swings over to the second toe. So it's more of an instability issue than anything else. And that's why when the big toe slams into the second toe, you end up with a hammer toe because the second toe has to get out of the way. It either goes up or down. So the bump, as I mentioned, is a result of changes in the bony framework. The big toe leans towards the second toe, which throws the bones out of alignment. So this is kind of a bone model over here of a bunion deformity and one of the corrections that you can do for it. And you can see the angle here. This bone right here should be parallel with the second metatarsal here. So it should be straight up and down. So what ends up happening is you actually have instability of this joint back here. So this is called the first tarsometatarsal joint. And I think especially probably in the podiatry world, this is most commonly missed, is, you know, with this joint being unstable, what ends up happening is this bone just starts to drift further and further away from the second. So bunions are progressive. They do get worse and worse. You can't stop them. You can't wear a splint and slow them down. Once it starts, it's a train that's not going to stop. It will continue to get worse. So one of the operations that you could do, this just shows a little image here. You take a little wedge out of the bone and you can see the whole goal of the surgical end of it is to straighten this bone. Because if you straighten this, then you can bring the toe back and get it square in alignment with the metatarsal behind it. So, and this is a picture over here of a before and after bunion operation. So what are the symptoms? Well, obviously pain, right? Bunions, they may not aesthetically look great, but I will tell you, unless someone has a severe bunion that is causing significant issues in the forefoot, meaning hammertoes 2, 3, 4, and 5, and the patient has diabetes and there are, you know, potential problems that can arise from it, I would say leave it alone. If a bunion doesn't hurt, I am not a plastic surgeon, right? So this is not about aesthetics. A lot of women come in and they, you know, they tell me the key word, well, it doesn't hurt, but I don't like the looks of it. They're going to have to go somewhere else because I don't fix them. However, people that do have pain, it is a great solution. It works. But it's all about expectations. So symptoms, obviously pain, you get redness and inflammation. You know, we live in Michigan. We wear shoes at least 9 months out of the year. So when you have a bunion, it's going to rub on your shoes. And so you get a lot of irritation. And the redness pretty much ends up being a bursa. So a bursa is a fluid-filled sac that forms over a bony prominence. So it's very common to have that in bunions, and that's when it gets bad because those become painful and it's very hard to calm that down. Especially, again, we live in Michigan, you keep on wearing your shoes, and that constant irritation just progressively gets worse. So some people come in and they say, well, my big toe's numb, you know, and whether their big toe whether the big toe bothers them or not, you know, their big toe goes numb. The reason that is because the nerves run right over, let me get this picture up here. The nerves run right over this bump right here, all the way out to the end of the toe. So when you put your shoes on repetitively, that nerve gets irritated, and then from the point of irritation and beyond, you get numbness. And so that may or may not come back. It just depends. Some people it does, other people it doesn't. Depends if the nerve is actually damaged or not. So pain in the ball of the foot and second hammer toe deformity. So these two kind of go hand in hand. The pain in the ball of the foot is actually the product of instability to that joint that I mentioned before. So it's this joint here. So what ends up happening is when we walk and we push off with our foot, you're supposed to bear the majority of the weight under the big toe. But when you have all that instability, what ends up happening is that motion, that excess motion that causes the bunion to begin with, elevates that first metatarsal bone, which is this bone here. It elevates it, and all the pressure gets transferred to the bone under the second toe, behind the second toe. So a lot of people come in, and they come in with a bunion, but they actually come in saying, hey, I've got pain in the ball of my foot. My bunion really doesn't hurt. It's driving me crazy. And in reality, it's actually an issue with the bunion. So that is one circumstance. I will fix the bunion to solve that problem because it is actually the bunion that causes the pain in the ball of the foot. So that is a very common thing that we see. So your visit to the surgeon or foot and ankle specialist. So things that we address when we see a patient for the first time. You know, we answer the question, is it really a bunion? Some people come in and they've got a bump on the top of the big toe, and that's actually arthritis. It's called hallux rigidus, and that's a completely different problem than the bump on the inside of the big toe. Some people have gout or have had chronic gout attacks, and they develop extra bone on the inside of the big toe. Some people have sprained their big toe in the past and do develop a bunion, but for a different reason. So we answer those questions by doing the following. Basically, we do a foot exam. We stand people up. We occasionally walk people and see their gait and evaluate their gait. You can't just assess a foot by seeing them sitting down, because with foot and ankle issues, it's all about biomechanics. So there are a lot of specialists, unfortunately, that don't actually stand people up. They don't get standing x-rays. The x-rays look completely different, non-weight bearing versus weight bearing. So those are very important things, because you can't even get a really good surgical opinion unless you stand people up. So foot exam combined with the x-rays leads us to the treatment options. So obviously, we really try our best to do as many non-surgical things as we can. So conservative treatment is our first line without question. Occasionally we do get people in that say, you know what, I've been to 2 or 3 doctors, or I've tried orthotics and anti-inflammatories, and I wear steel-toe boots and I'm just miserable, do something. And that's a different scenario. If people are just done and they've tried everything under the sun, they've kind of come to grips with it and they're waving the white flag. But most of the time we do try to treat people conservatively. So let's talk about those options first. So we can do shoe modifications, bunion splints, toe spacers, padding, and orthotics. Shoe modifications are probably I would say, going to give you the best result to the patient. Essentially, it's making room for the foot and the bunion. A lot of women, I hate to call you out on this one, but I mean high heels to flats to shoes that are narrower than their foot. I mean, it's, and then they come in and ask why their foot hurts. There are several instances where if you just get a wider shoe that fits your foot a little bit better, your pain goes away. And if it does, you just saved yourself a big hassle. So shoe modifications are huge, but there are a lot of women that just don't want to deal with that. They want to wear what they want to wear, and that's a goal of theirs. And you know what? It is a quality of life thing. There's a lot of professional people that want to wear certain shoes, and it's a high priority for them, and we understand that as well. Bunion splints. So if anyone's ever been on a plane and you see the Sky Mall, right? You could spend like $10,000 in a Sky Mall magazine on bunion stuff and plantar fasciitis. Bunion splints don't work. So one myth I want to expel: you can strap that big toe over and torture yourself for as long as you want, but it won't retrain the big toe. It won't create stability to the big toe. It just won't happen. It's unfortunate, but it is progressive, and the second you take that splint off, even if you had it on 6 months, it's going right back to where it was. Toe spacers. Toe spacers, those are used primarily in people that have bunions, but significant bunions where it's abutting the second toe. So we get a lot of people that come in where they get a big callus between the big toe and the second toe, and that's really the most painful thing that they complain about. So in those scenarios, toe spacers can help. You can get a silicone spacer, you go to Meyer, the foot section, and they have plenty of options there. So toe spacers do work. Again, it's a Band-Aid. It's not going to fix anything, but they can help make you more comfortable. Padding and orthotics. So a lot of foot and ankle specialists, they address this with padding, and I do with orthotics occasionally. However, I will tell you, it's kind of a catch-22, because with bunions, our goal is to get more room in the shoe so it's not rubbing so much. But the second you get someone into orthotics, even if it's a custom one, it does take up a significant amount of room in the shoe. So there's kind of a fine line. They can actually make a bunion hurt more, unless you typically have to go up about a half size more in order to accommodate an orthotic. So what an orthotic does is it actually creates a little bit more stability to that midfoot joint that we talked about a couple minutes ago, and that can actually slow down the progression of a bunion a little bit. But again, it's about shoes, and with women, I'm going to tell you that it's pretty much a tennis shoe if you're going to go the orthotic route. So unfortunately, there aren't little rinky-dink devices that are going to fit in a heel or a flat that are going to do anything. So you can spend a lot of money on that front too, and it's not really going to help you a whole lot unless you're committed to pretty much wearing a tennis shoe or a walking shoe or something of that nature. So the surgical treatment, what it does, well, it corrects the bony alignment, and that's our main goal. It removes the bump and corrects the soft tissue. So one thing we didn't talk about yet is the soft tissue. So the bony alignment, obviously, we evaluate on x-ray, and our goal is to get that poker straight and look really nice. But one thing you also have to address that's just important is the soft tissue around the big toe joint, because every joint has ligaments that connect bone to bone. So as you saw in those pictures, the big toe deviates, and those soft tissue structures get stretched out. So when you straighten out the bones but don't address the soft tissue, that toe is just going to deviate right back to where it was. So you got to tighten up the soft tissue and take out a lot of that attenuation or stretch, and tighten up those ligaments as well. So why it's done? Not for cosmetics, number one. It's done to reduce pain, increase function, correct the deformity, and prevent further deformity. So I think the most important thing here is the idea to prevent further deformity. And what I mean by that is people that come in with a bunion and they have pain under that second toe or the bone behind it, and they're starting to get changes to that toe. What can happen is as that bunion progresses, that second toe is going to continue to pop up more and more. The hammer toe gets worse, and then it's a trickle effect. So the big toe is like a wrecking ball in those situations. It's the second toe, then it's the third, then it's the fourth, then it's the fifth. So I would probably venture to say about 30 to 40% of the bunion hammer toe combinations that we do, it's all five. It's bunion and hammer toes 2, 3, 4, 5. Because what happens is they all deviate, and you can't straighten one without getting the other one out of the way. So you got to end up straightening them all. So that's what I mean by preventing further deformity. Once you see it starting, there's kind of that fine line where there is some benefit to doing it sooner than later, rather than waiting. That's waiting. So, and believe it or not, we see that every week.
That's waiting and crossing your fingers.
Yeah, exactly. That's right, right. No bunion splints for them. So, you know, we try to choose the right procedure for everyone. We base it on the x-rays. We base it on clinical evaluation. We base it on the age, activity level, and more than anything, what is the patient's expectation? So, do they do yoga? Do they cross-country ski? Do they downhill ski? Do they run? Do they, you know, all these different things play a huge role in what operation we choose. And we help them choose if that's the case, if they're to that point. And, you know, a lot of people that get to this point, they just want to walk. They just want to go for mile to 5 mile walk and stay healthy and active. You know, when people hear of stories about bunion operations and hammer toe operations and they get a little freaked out, yet I talk to them and they say, well, I don't really walk, I don't exercise, my foot's killing me, but I also have heard horror stories. Well, you have two options: do nothing, or, you know, let me talk to you about the expectations that I have, and if it sounds good to you, let's get you active again. And so once you hit that point, you know, there are several great options for patients. So after surgery, again, this is the key. Recovery takes several weeks, and you have to expect that you're going to be off your foot for a period of time, okay? If it is hammer toes in isolation, which isn't as common, but if it is, and we can get away with that, typically your heel touch weight bearing in a boot or a surgical shoe for about 6 weeks, okay? If a bunion, any bunion operation is involved, it's typically 6 to 8 weeks of being non-weight bearing, okay? So what ends up happening is this. People have terrible outlook about bunion surgery, I think, in my opinion, because of one main thing. That's because the surgeon did not do a very good job to say, hey, this is going to hurt for a while. This is an investment. This is a marathon, not a sprint. Too many people say, oh, you know what, 5 weeks, we'll get you through this, you'll be cruising, no big deal. Well, it's no big deal to the surgeon, but it's a huge deal to the patient that has this expectation that they're going to be running a marathon in 5 weeks. So in reality, outcomes are great if expectations are the same. So that's the key. And I am a firm believer in telling a patient how it is. I get it. If you tell someone what they want to hear, sure, you can talk them into anything if it sounds awesome. But that's not fair, and that's not how I do it. It's not how my brother James does it. But in reality, you have to understand that this isn't a quick fix. It's just not. It takes a while. And you know what? With every step you take, you bear 3 times your body weight on your foot. When you run, it's 5 times your body weight. So you can imagine just the rehab and the post-op course, it takes a while. But you know what? I wouldn't have a job if it didn't work. It does work, and it works well. So this is just a little quick rendition of the stages of bunions. Initially, you start to see the slight bump. People are like, man, did I bump it? Did I wear the wrong shoes? What in the world happened? That's typically what happens first. And then in that typically 25 to 55-year-old range, this is all a bunch of mumbo jumbo, but basically it's saying, people typically that have bunions, they have a slight flat foot deformity. That's what the pronation means. The foot continues to pronate. When people have flat feet, that worsens a bunion and it makes it progressively faster. And what happens is the foot rolls in and it shoves the big toe out. So it creates a lot more instability at a faster rate. And then stage 3, that's where you get the underlapping of the big toe under the second or vice versa. And at that point, typically the second, third, fourth, and fifth toes all start to deviate. So again, you got the bump here associated with hammer toes 2, 3, 4, and 5. So you can see they're getting calluses on top of these toes, and that's what bothered this patient the most. Again, this one's going over the second toe, and this patient also had a significant callus that formed, so the toe spacer that I was talking about, this would be a patient that if they, surgery wasn't an option or that wasn't what we wanted to do, a toe spacer would be a decent option for this one. So this is just a quick example of post-surgery and what we try to do. So you can see the first metatarsal, this is preoperatively, right? It's angled away from the second. So our goal is to straighten the first metatarsal and make it parallel with the second. And we use a couple screws, and we fused this joint, so we welded it together. So a lot of people get concerned, like, oh my word, I don't want my foot fused. Why would I do that? Well, in reality, what this does is this reestablishes stability. So this is called a non-essential joint, and that's what people need to understand too. So there are essential joints and non-essential joints. The ankle joint is an essential joint. The joint below it that allows us to walk on uneven ground is an essential joint. This one is not, so you really get very limited excursion, and with bunions, that joint moves way too much. So what it does is it actually establishes what you should have. So in reality, you don't lose any motion with that. So let's go on to hammer toes. So these are different examples of hammer toes. This is a younger kid, and these are called mallet toes, and we'll talk about that in a minute. You have the traditional hammer toes, and then you've got the claw toes. So what I'd like to go over, we've got the types, we've got the symptoms, how they develop, and various treatment options for them. So what is a hammer toe? Well, basically it's an abnormal bend to the toe that stays in one spot, and it's on the second, third, fourth, and fifth toes. So here's the examples here. So there are 3 different types here. So we have the traditional hammer toe. This is by far the most common. And you can see this is the whole toe right here. So you have one joint here and you have one joint here. So a hammer toe is where you get contracture Am I losing the battery here? You get contracture of the first joint here, okay, and the rest of the toes stay straight. A mallet toe is where the first joint's straight, so the first two bones are nice and straight, but the very tip of the toe bends down. So these people get painful calluses right at the tip of the toe where the nail hits. Then you have claw toes, okay? Claw toes are where both joints are bent, and these toes are typically associated with people that have had neuromuscular issues. They've had a stroke, a disorder called Charcot-Marie tooth, or people that have a really high arched foot. So those people typically develop more of a claw toe due to the instability in their arch. And the mallet toes are typically found in kids. I see them typically around the age of 4, 5, 6, 7 years old. Yes, you know, it can trickle into the adult age, but most of the time it really drives patients nuts. Kids will kick their shoes off all the time, so the parents bring them in. And you know, the earlier they come in, the easier it is to deal with, because what ends up happening is if a hammer toe is left alone for long enough, it turns into a fixed or a rigid deformity versus a flexible one that you can manually reduce. So with time, they do become rigid. So they start off mild, but they do get progressively worse. Again, the word progressive, hammer toes and bunions, they just keep going. They can rub against your shoes, and they typically don't get better without some sort of treatment. So symptoms, obviously you get a bend in the toe, you get irritation, and typically it's right on the knuckle, right on the top corner of that first joint is typically where patients have the most pain and irritation. And that's where they get corns and calluses and develop the redness and inflammation. So in the more severe cases, and it's not necessarily severe hammer toe cases, but more urgent cases, patients with diabetes. There are a lot of patients in our community with diabetes, and the problem with patients in diabetes isn't necessarily the hammer toe, it's the fact that they can't feel their feet. So they get what's called neuropathy. When you have neuropathy, it always starts in the feet, and what ends up happening is you can't feel if your toes are even rubbing. I've had patients come in that have had a nail driven right through their shoe, and they've put their shoe on 5 times that day. So they can't feel it. So what happens is this callus turns into a blister, turns into a sore, turns into an infection, turns into an amputation, because they don't catch it soon enough and they come in and their foot's at risk. So these types of deformities, that's one instance where we need to address it sooner than later. And in those patients, what I try to do if we catch the ulcer before it gets too bad is we try to get that healed, and then I'll fix it, because we know it's going to be an issue. Then we'll straighten it out in order to help save their toes so they can continue wearing their shoes, because they're difficult to find shoes for some of these people, and they have to work. And if they have a factory job, or they're working on their feet all day, or they're wearing steel toe boots, they're caught between a rock and a hard place. So an operation may be in their future in order to save their foot and prevent them from having these chronic issues. So if left untreated, the toe can become more rigid. And typically they don't respond to conservative treatment after a while just because they become fixed and rigid. That means you can't manually straighten it. When they're flexible, yes, they're still crooked, but you can actually physically straighten it, but then when you let go, it bounces right back. The difference is when they're rigid, you have to do a little more work from a surgical standpoint to straighten it. Outcomes are still great. That part of it doesn't necessarily matter, but it does entail a little bit more work to fix them when they get to that point. So again, just like I did with the bunions, your visit to the specialist here. We do a foot exam, we take x-rays, we get an accurate diagnosis to really look at, is it a mallet toe, is it a hammer toe, is it a claw toe, and what do we need to do to straighten it. On top of that, you have to look at the bunion, because there are a lot of people that come in that have a bunion and they say, you know what, I don't want my bunion addressed, but I want my second toe straight. And it's like, well, you can't do that. Unfortunately, you have to you have to fix the bunion in order to address the second toe. So that's where it's tough, because yes, it is a little bit more involved of an operation. Still works great, but it's unfortunate that you have to have the whole kit and caboodle, but it's not doing the patient one favor if you try to fix the toe and you don't address the bunion, because that hammer toe will come back in 2 seconds. So then we develop a treatment plan. Again, surgical or non-surgical. So hammer toe surgery, what are the goals? So obviously it reduces the bending, so we straighten them out. And it puts the toe in a much better position. We do it for pain relief, improve function, decrease the deformity, and again, like I mentioned before, in patients with diabetes, we do it for limb salvage sometimes, even hammer toes and bunions. But one reason why it's not done, cosmetics. So, how do we choose the right procedure? Well, again, we do it based on x-rays and age, activity level, and again, comorbidities. What other factors are there? So the surgery for both, correcting a bunion and a hammer toe. That is very commonly done. We do it every week. There are a lot of people that we see that have the combination of the two, like I said. We also see people that not only have the bunions and hammer toes, but also have flat feet and high arch feet that are definitely causing some of the problems. So it's not uncommon that we fix a flat foot when we're fixing a bunion. Because again, what happens is if the foot rolls in and it pronates significantly and you try to straighten the toe, you can imagine all the pressure is pushing the toe to the side again. So rebuilding that arch takes all the pressure off the big toe, and it ends up, with a much less chance of any kind of recurrence. So what to expect with recovery? We touched on this a little bit earlier. The recovery, it'll depend on what other procedures were performed. So again, just to reiterate, hammer toes alone, typically 6 weeks, but you can put some pressure on it, mainly on the heel. If any type of bunion operation is done, it's 6 to 8 weeks. And if it involves the Achilles tendon or a flat foot reconstruction, high arch reconstruction, that type of thing, then it's for sure the 8 weeks. So ultimately, at the end of the day, I think the take-home message is, there are some conservative options. Unfortunately, there are not a whole lot. The shoe modifications, I think, are the number one thing. Surgery, again, it's all about expectations. The outcomes are good. It just takes a while. You just have to know it's not going to be 5 weeks. It's going to swell for a while. There's some rehab that goes into it. But patients do well, but you got to have the right mindset, and you got to understand that, you're going to hate me for a little bit, but then, we're friends, a few weeks down the road. So that's basically it. So, if you're struggling with it, I'm right in Coloma, a couple miles away, and I'd be happy to answer any questions at this point. What do you guys have? What questions do you have that I didn't cover? Yes, sir.
In case of like flat foot or high arch, I would assume those primarily two conditions or state of your foot is primarily, if I'm not mistaken, probably at least 80% probably based on being passed on from generation to generation?
Yes, it is hereditary for sure. Bunions, hammer toes are subsequently, obviously, mainly the primary cause of them are the bunions, but flat feet are definitely hereditary. And I get families after families with sisters, brothers, moms, dads, grandmas. Yep, you name it.
So what's the number one thing that we can do to, you can't beat what you're given, but if you're not literally buying new shoes, say every year, or if you're buying a cheap shoe, aren't you basically asking for trouble quicker?
Well, it's more of finding a comfortable shoe. So a lot of people want to wear the shoe they want to wear, and they'll suck it up and endure the pain, but the problem is once that becomes inflamed, that bunion, it's kind of a downhill battle because it's a cascade effect, and it gets worse and worse, especially women that wear really narrow shoes. that'll progress a bunion much faster. So if you kind of jump on it and at least make yourself more comfortable by wearing a shoe that fits your foot well, you can definitely slow down the progression, but it won't go away, and you can't really stop that progression. But you can slow it down for sure. Yes?
So if you have it in one foot, a bunion, what's the chance of the other foot?
That's a good question. I get asked that almost every time. So basically, what I've come to realize is, just like we're right-handed, left-handed, right? We have a dominant side between each foot. So whether it's your right foot or left foot. The dominant side typically is the worst side. So you come in and say, hey, I've got a bunion on my right foot. It's killing me. My left side, a little bit, but it's not bad. It doesn't bother me. The unaffected side is typically 5 to 10 years behind on average. So, I'm not saying that, and you know what? Because it's your non-dominant side, even if you develop a bunion, it may not bug you. And if it doesn't, leave it alone. But typically, you do get it. It's just later on. Yes, sir.
Because if you're a runner or a basketball player and you're kind of harder on your feet, does that typically progress the bunion quicker?
Not necessarily. I mean, I guess it could a little bit, but I would never, ever, ever tell someone to not be active, exercise, and do what they want to do. I wouldn't, because again, it's all about quality of life. So what I would tell you as a patient is do it as long as you can. And if you get to a point where you can't enjoy the things that you want to do, well, then maybe it's time, and you've done everything conservatively to try to keep things at bay. That's my rule of thumb. I'm a big, I play a lot of sports. I wakeboard. I try to stay active. And again, I want to keep my patients active. So that's one time where I think that, if you got to the point where you couldn't do what you wanted to do, that's an indication for surgery if nothing else is working. But I would never tell you, nope, stop what you're doing, sit, be on the computer, watch TV versus be outside and do the things you want to do. Yes, sir.
Can we slow the progression by maybe buying a wider shoe and stuffing another sock in there, or would that cause other issues?
Well, that may cause other issues, but you can get definitely a wider toe box so that the heel isn't slipping. So, what you don't want is you don't want the shoe so sloppy that you're getting blisters, because that shearing and that motion can cause blisters, especially if you're a runner. So I would tell you that you want the toe box wide enough to be comfortable. Because, the narrower the shoe, if you're cramming your foot into a shoe that's pretty narrow, you can speed things up. Yep.
The problem's typically not in the toes, it's in where the bunion forms.
Well, that's what
Over the toes to the side.
Right, and that's what I mean. The very front part of the shoe is, and you know what? Sometimes you can find a shoe that works well for you, and you can go to a shoe store and get it stretched. And I tell patients that a lot. You can definitely have that. That's one of the modifications that you can do, is stretch it right where that bump is. And you know what? For as long as you get, keep rolling with it. Yes, sir.
I have a hard time reconciling I have familial neuropathy.
Okay.
Okay.
Yep.
I have a hard time reconciling that with the pain from bunions. Because I have pain from bunions,
Yep.
but it doesn't seem like I should.
I understand. I understand. That's a tricky question.
It is a trick question.
It is. There's orthopedic pain and there's nerve pain. And that's where it is tough to kind of ascertain, because are both feet similar?
Yes.
They are. Okay. In appearance too, as far as the bunions?
Yeah, well, one's a right and one's a left.
Well, exactly. Exactly. That's a good point. That's a good point. Yes. Yes. What I typically tell people, there are specific things that kind of pinpoint whether it's nerve pain or it's orthopedic pain. And a lot of it depends on, do you have pain with activity? A lot of people say, my feet kill me at night. A lot of people with neuropathy. where they lay down and they have more pain after they go to bed than they do during the day. That is definitely more nerve pain than orthopedic pain or bunion pain. So people that say, you know what, I'm fine when I don't wear shoes or I'm walking around the house and whatnot, or you know, after I get off my feet, I just got to get off my feet, but the second I put my shoes on or I'm at work all day, that is bunion pain. So it's a matter of breaking it down on when it hurts.
Okay, thank you.
That's the best way to figure out, is it bunion or is it nerve pain?
Thank you.
Sure. Yes, sir.
Does surgery generally require hospitalization, or?
No, nope, it's outpatient. Yep, the only time it would require hospitalization, obviously, is if someone had comorbidities that would, you know, if they had any heart issues or anything, that it would be safer maybe to keep them a night. But 99% of the time, it's you're home same day. Yep,
When you're off your feet, it's with one of those little scooter type things?
you got it.
Okay.
Yep, yep, the knee scooter. Yes, ma'am.
I saw that on one of your slides, you said that changes in bone structure in your feet could be part of the problem. You have a Morton's neuroma? Is
Yep.
it that?
No, nope. So a Morton's neuroma can cause the toes, I don't know if you've seen, it can cause the toes to kind of deviate a little bit, but a neuroma is much easier to deal with than, you know, the bunions and hammertoes, especially the post-operative course. But that's completely independent. That's its own separate deal. Yep, yep. Yes.
Can that instability in that joint lead into back pain if you walk?
Well, you know what? What leads into back pain, as far as your feet go, are when you have pain for long enough that you're starting to compensate. So are you walking on the outside border of your foot? Are you, you know, and a lot of people don't even realize it. And it's funny because a lot of patients, we get an x-ray, and again, we get all standing x-rays, and the foot looks completely rotated, and that's because they're so used to rolling their foot out that their x-ray isn't right. So I have them redone with their foot in a normal position, but that cues me right out of the gate before I even see them that they've had this for a while. So in relation to your back, it is extremely common for my patients to have back pain. And you know, the second we get that foot addressed, whether it's, again, orthotics or something conservative or the surgical end, it can definitely address back issues. It's like a chain link fence. If your foot's twisted, everything else is up the chain and it ends at your back. Yes?
Can you tell us a store where you can do a nonstop shopping for toe box shoes that are made for us? Because the wide shoes don't do it for me. And
Yep. Where I would go, one of two places that I'm most familiar with. One is Corey's Bootery, and that's in Kalamazoo.
is that with a C or a K?
A C. Yep, that's right off 94. And then another one is V&A Bootery, and that's in Portage, right outside of Kalamazoo. And they're both very good, and they do a great job at getting people into, and they have really good shoes, but they also have, you know, the diabetic shoes and whole sorts of different things.
And then, so you're saying that we shouldn't rush out and go online and order the bunion booties?
Save yourself some money. Trust me. It's amazing how they make it look. It's crazy. It's actually, it's a borderline crime because what they do is they target people that haven't seen someone yet.
Yeah.
And they're doing everything they can to try not to see someone, which I get. But you know, people end up spending $200-300 in a heartbeat on all this random stuff, and it's, you know, I feel bad, but you know, so no, don't do that. Oh, yep, I'll get to you in a minute. Yeah, go ahead. Oh, okay, go ahead.
Are there exercises that you can do for your feet to help, like, strengthen your bones? And I know you talked earlier about yoga. You know, in yoga, they emphasize, like, working on strengthening the bones in the feet.
You know, you're not really going to strengthen necessarily the intrinsic muscles of the foot in order to, realign the toe or slow the progression. I do use physical therapy for, certain patients and scenarios from a conservative standpoint, but it's more to address inflammation than it is stability, because the stability is just the biomechanics you were born with. So there aren't too many exercises with an exception of the Achilles tendon. So Achilles tendon stretching is probably the best thing you could do for your foot, because the tighter the Achilles is, the worse it makes your flat feet, the worse it makes your bunions, the worse it makes your hammer toes. The Achilles tendon's the strongest muscle unit in the body, and when that is tight, it will win. It'll beat everything. So the foot suffers. So that is actually the number one operation that I do, is addressing the Achilles tendon, believe it or not. It causes heel pain, bone spurs in the back of the heel, flat feet, I mean, you name it. It's involved in everything. It's also the number one surgery I do in patients with diabetes, to offload the foot. Because the tighter that Achilles is, the more it pulls that foot down, and it puts all the pressure on the ball of the foot. So, does that help?
So like flexing the foot?
Yes. Yep. All the stretches to stretch that calf muscle. Yep. Okay.
I'm going to need another hip replacement and a knee replacement and the feet done.
Okay.
Okay, what option would it be better to do the feet first, or the hip first, or the knee first?
Yep. That's awesome.
Do it all at once, you recuperate.
Exactly. Oh, I love it. I know, seriously. I don't blame you. Well, typically, when it really matters from my standpoint is the post-op recovery. So let's say it's your left foot that's the worst, okay? So if you're having a bunch of pain on your right hip and your right knee, I wouldn't do your foot first, because you need that other side to stay off of it. So if it's going to make you cheat and put weight on it and walk on it, that'll compromise the result. Does that make sense?
Yes.
So not only that, let's say your knee, a lot of patients with knee arthritis, they have what's called genu valgum, and that's where there's a deformity at the knee and it kicks their knee out, right?
Yes.
So that can change where I would position your foot. So it's more important to do the knee first, and then I do the foot based on your knee position.
Okay.
Because if I put the foot in a certain position, they can change it with the knee.
Okay.
The hip doesn't matter nearly as much, because that's more of a rotational position than anything else, but the knee definitely matters.
Okay.
Okay?
That makes sense.
Yep. Top to bottom. Yes, ma'am.
How long does surgery usually take?
It depends. I would say, let's say from the extreme, so if we're doing flat foot, bunion, all the hammer toes, it takes me about an hour and 45 minutes.
That's it? Wow.
Yeah, I mean, we do it a lot. We do them all the time. So this isn't a 5 times a year, unfortunately, hence how many people are in here right now. So, let's say it's just the bunion. It takes about 45 minutes, I'd say, something like that. So it just depends what's involved. Yep. And you know what? It depends on the staff that works with me. And we have such an awesome staff here that, they've done a million of them. They've seen them. They could probably do it, And so it really helps having the same staff every time, because it's just like clockwork. And it makes for a much more efficient and productive operation as well. Yes, sir.
I've had flat feet my whole life. I wasn't aware you could fix them. What do you do to fix a flat foot in surgery?
Yep. So with flat feet, a lot of it, again, deals with instability, but the number one driver for a flat foot is the Achilles tendon. Okay, so every single flat foot that you fix, you always address the Achilles, and that means, lengthening it and getting a little bit more motion out of the ankle. So then what we do is we do a structural alignment of the foot. So we use a little bone graft to swing the foot over and around, and then basically we do a tendon transfer, because what happens in a flat foot is there's a tendon that holds up the arch that fails. So in that scenario, God gave us a tendon to spare, so we use a tendon that runs right alongside it, and we replace it, and that does the job of the old tendon, and it works out great.
Were my flat feet something that developed? I thought I was born with them.
No, you were, but what ends up happening is that tendon that's designed to hold the arch up, it's so attenuated or stretched out, it's non-functional anymore. So when we do the reconstruction, we take a tendon that works well and we replace it, and that gives more function to the foot in the appropriate position.
Thank you.
Yep. Yes, sir.
Where does the tendon come from?
Where does the tendon come from? So that's a good question. So where it comes from, you have tendons that pull all the toes down. They run all the way to the very end, okay? And it starts in the back of the, here, I'll show you on this model here. So it starts in the back of the leg, okay? This is the right foot. Starts in the back of the leg, comes down around here, and then it splits into 4 tendons, and it pulls the toes down, okay? So the tendon that holds the arch up runs right in front of it, down here, and that anchors in right here, and so that pulls and helps support that arch. So the nice thing is, the way that we were made is we have another tendon that comes down behind that one. So there are 3 on the inside of the ankle. Comes down and it goes to the big toe, okay? Well, there's a connection right in the bottom of the foot that connects the tendon that pulls the big toe down and the tendon that pulls these down. So I cut the tendon right in the bottom of the midfoot, but the nice thing is I cut it right behind that connection. Okay, so yes, I take the tendon that pulls these down and give it a new function, but the nice thing is the big toe takes over with these. So you literally don't even notice. There's no functional difference. You'd never be able to tell that we took that tendon. Nope, nope, it's your tendon, and it's all done through the same approach too, which is nice. It's all right there. Oh, just 1 minute. I'm so sorry. Yes, sir.
Well, like a tendon, you say you cut the tendon, then you have to put that tendon back together again, or?
You know what? I anchor it into the bone.
Oh, you anchor it into the bone?
Yep. So, you know, that tendon that failed, you know, causing a lot of the flat foot, I anchor it right into here where that other one was. So I replace it. So it basically functions exactly like the other tendon did. Yep. And it's called, this is probably getting a little too in-depth, but it's called a functional transfer or an in-phase transfer. And what that means is you're taking that tendon that performs a certain function at a certain time in our gait, and you're transferring it to a spot that performs a function in the same time. So there are other transfers where we call them out-of-phase transfers, where we take tendons from the back of the leg for a drop foot, in a drop foot case, for instance. We take tendons from the back of the leg and we pass them in between the bones in the front and anchor them to the top of the foot. So that's an out-of-phase transfer. So physical therapy has to retrain that muscle to pull the foot up instead of pull the foot down. So with a flat foot, though, it's an in-phase transfer, so rehab is quick. You don't even have to think about it, and it just does its thing. Does that help?
Mm-hmm.
Yep.
So if you do that operation with the flat foot on, the foot with the bunion,
Yep.
don't you walk a little funny because the other foot's flat?
You know, a lot of people ask that question too. No, that is not the case. No, it's that's a great question. I completely understand what you're saying, but no, when someone has, a little bit higher arch and a little bit lower arch, people do just fine, and there hasn't been any functional deficits. There hasn't been any limb length discrepancies. Because your body with a limb length discrepancy can adjust for about a ½ inch. And so really people do just fine. I certainly wouldn't fix the other side just for fun. Put it that way. No, patients afterwards don't say a thing. They do fine. What's that?
You don't have kids that are getting ready to go to college.
No, I do not. No, I do not. I'm a ways away from that. Yep, I am. Yes, sir.
So orthotics or ticks, or however you call them.
Yep, the orthotics.
Orthotics.
Yep.
Those wouldn't even do you any good for your flat foot then, would it?
Well, yes, they can actually help a flat foot much more than they can help a bunion. They're not gonna correct your flat foot,
Right.
but they can help with your symptoms.
I see.
So they can't, that's the number one thing we use conservatively for people with flat feet. Yep, and some people, works great. Other people, it just depends, because the Achilles tendon is, again, tight in every single flat foot that comes in, and it's all a biomechanical issue. So sometimes that Achilles is so tight that it just forces that foot to pronate so much that when you put an arch support in, they actually have more pain. So in that scenario, it's tough. But for the most part, orthotics do work pretty well for flat feet. Yep. But more of a custom one probably than over the counter. Not all the time, but I try to get people into a custom one that's really going to help hold their arch where it should be.